Thank you for participating today. We're going to talk about epilepsy in pediatrics and our new treatment options. Let me just pull up this slideshow for you. Hang on one sec. Can you all see my screen that doesn't have anything on it at the moment?
We cannot yet, no.
All right, hang on. So my name is Patty McGoldrick. I'm a nurse practitioner at Maria Ferrari Children's Hospital and Boston Children's Health Physicians of New York and Connecticut. My partner is Steve Wolf. We have been doing this, taking care of children and young adults and people with developmental disabilities and epilepsy for a very long time, 23 years together. And I want to thank you. You guys did a presentation yesterday and gave an award to our partner, Harriet Kang, for 30 years of service to the Epilepsy Foundation. We are both on the board, the advisory board of the Epilepsy Foundation of New York City. And so we're pretty involved with them. And let me just find my my PowerPoint here, so I apologize. I don't like being late. Just gonna look for this. So I'm going to talk, and then there'll be time for some questions afterwards. Are you mostly parents, providers? What's the group makeup here? You guys can unmute and tell me or put it in the chat. Can you hear me?
Hi, Patty. This is Sandra Spinelli. I'm a representative with Nervous, but I'm also a parent of a child with epilepsy. Great to have you.
Thank you. It's good to see you. I'm just still trying to find this, pull this up. So one sec. It's been a day.
In the chat, we also have a grandparent and a nurse educator on as well.
All right, good. Do they have questions? Or I can't read the chat while I'm trying to find my PowerPoint that has.
And no questions have come in so far.
All right. Sandra, am I doing the Neurelis deck or I'm doing the
I'm just listening as a parent today. You're doing the epilepsy deck.
Yep, absolutely. So I wanted to talk today about changes in pediatric epilepsy, and I gave this presentation recently with my partner, Steve Wolf. So I don't know why it's not coming up. This is really embarrassing. All right, well, I'm going to do this one that I'm doing. Oh, this is good. Now we have a blank presentation. It's just getting better and better. But hang on one second, guys. All right, now we got it. All right, can everybody see now?
We cannot see your screen yet, no.
Can't see my screen. I don't know why I'm on. You know,
Here we go. Yep.
Okay, you got it. All right. Thank you. Sorry, guys, about that. All right. So we're going to talk about epilepsy. So updates in pediatric epilepsy treatments. So there's about 70 million people worldwide who are living with epilepsy, and about 3.5 million in the United States have epilepsy, which makes epilepsy the fourth most common neurological disorder in the United States, with 150,000 new cases of epilepsy diagnosed in the United States every year. Which is a large number. Now, if you look at the incidence of epilepsy, this is a chart. Now, this dates back to 2005, but nothing has changed. So you see there is a big group of people with epilepsy under the age of 20. It kind of levels off then until people get to be about 70 and they're getting sick with other things. So as you can see, the group that we're looking at is this group in here. These are our pediatric epilepsy patients. So what do we do to diagnose epilepsy? So a seizure is sort of a big burst of electricity in your brain all at once. It can be one area of your brain, it can be your whole brain all at once. And what we do is we then divide the diagnosis into either focal or localization related, which means that the seizures come from one area, or generalized, which means the whole brain kind of lights up with electricity all at once. So what we do when we first see people having seizures and we try to make the diagnosis of epilepsy, we can't make that diagnosis until you've had 2 or more unprovoked seizures. So that means seizures that don't occur because you're drinking alcohol or you're sleep deprived or you're sick. What we then do is we do 3 tests. One is an EEG. We usually do an overnight EEG, and that looks at the electricity in your brain. We do an MRI. Sometimes we'll do a CAT scan first, and the CAT scan looks sort of globally at your brain and your head to see if there is any bleeding or tumor. An MRI is a better look at the brain itself, so that it's thin cuts, so that you look at very small pixels, small little cubes of the brain. So it's cut vertically, horizontally, and that way you can sort of piece it together into these little squares or these little cubes. And we also now are looking at genetics. So that's part of the initial workup to see if there's some genetic reason that the child is having seizures. The reasons that we do the genetic testing is so that we can put an end to the family's journey. So we can tell you definitively, does the child have a genetically based epilepsy? Makes parents feel so much not guilty anymore, because this is nothing that they had any control over. Not that epilepsy in general is something they have any control over. And it allows us to access support groups and foundations who deal with many of the epileptic encephalopathies or the epilepsy syndromes. And it also allows us to do genetic testing in other family members, especially those who might be having babies. So the facts on anti-seizure medication, what we use to control seizures and epilepsy initially, they used to be called anti-epileptic drugs, but now we call them anti-seizure meds. That's the primary way in which we control seizures. So it's almost always the first therapy. The benefits are that medication controls seizures for about 7 out of 10 people. Different medications are used with different kinds of epilepsy and seizures. So if you have focal epilepsy, it's one kind of medicine. Medicines that are used for focal epilepsy can make generalized epilepsy worse. So that's why it's important to have the EEG. And there's more than 25 anti-seizure meds on the market. It's more than that now. This is from 2000. The limitations and the risks with the treating with medication are there. You can have side effects, so drowsiness, dizziness, confusion. And that with each subsequent medication, there's a decrease in their ability to stop the seizures. So when you start with the first medication, there's about a 40% chance that the seizures are going to stop. With each subsequent medication, it goes down to like 30% and then to about 5%. Only 4% of people are seizure-free after they've been on the 3rd medication, and only a third of people do not achieve seizure freedom with medication. So as you keep adding more and more medications, the chance that you're going to be seizure-free gets less and less. And that's why at that point, if you failed 2 medications, just 2, then we need to look at other options for treating. Now, we also look at the comorbidities of epilepsy. Strong correlation with learning disabilities, attentional issues like ADD, anxiety and depression, strong correlation with cerebral palsy and autism. Autism, it's really greater than a 40% chance of developing epilepsy. They also have trouble, people with epilepsy also have trouble with sleep, with cognition, and with feeding. There's something that we don't talk about often enough, and that's SUDEP. And everybody's sort of afraid to talk about SUDEP. SUDEP is sudden unexplained death in epilepsy, and there's about 1.2 cases of SUDEP in every 1,000 people with epilepsy. And what is SUDEP? It's a death that's not caused by injury or drowning or any other known causes, but occurs in a person with epilepsy, mostly during or immediately after a seizure. The exact cause is unknown, but the risk factors are presence of generalized tonic-clonic seizures, frequent generalized tonic-clonic seizures, 3 or more per year, not adding an additional medication when patients are refractory, or going to a different treatment option. So that's the people. I'm here right now in a clinic for people with developmental disabilities, and many of them are on 7 and 8 different medications. We've just taken over this program, and our goal is to simplify the regimen so that they have fewer side effects and also get the correct medications on board. Another risk factor is if you haven't been seizure-free for 1 to 5 years. We think that what happens is that the seizure occurs and there's breathing difficulty and an abnormal heart rhythm. So what we advocate for is supervision at night, somebody either in the room with them or a camera or a seizure alarm so that people will know if there's a seizure going on. So now let's talk about the newer treatment options, which is what I'm talking to you about today. So newer medications and then surgeries. So what we need to do is we need to do sort of a personalized medicine and identify what kind of seizure the child is having. Does it meet the criteria for a syndrome or a genetic epilepsy? And then use the medications that are indicated for that syndrome. The one that I think is most common is called Lennox-Gastaut syndrome. This starts in childhood, but it doesn't go away. So often it occurs after people have had infantile spasms. There's an abnormal EEG with a 3 Hertz slow spike and wave. They have multiple seizure types, including generalized, tonic-clonic, atonic, which are the drop seizures, focal seizures, myoclonic, which are little quick jerks, and tonic seizures, which are stiffening and often occur in sleep. They often have some sort of a cognitive disability, and it can range anywhere to a mild learning disability all the way to severely disabled. Dravet syndrome is another genetically mediated epilepsy. It starts in infancy. These children are typically developing, and then they start having these long hemiclonic seizures, so sort of half of their body. They're triggered by changes in temperature. So it can be a fever. It can be a change in the temperature, like jumping into a pool in the summer, going in and out of the bathtub. The seizures last for a long time, and there may be an associated movement disorder, sort of an abnormal walk and some tremors as they get older. It is a sodium channelopathy. So what we need to do is to not use medications that work on sodium channels. And that's important, and that's another reason for doing genetics. There's tuberous sclerosis complex, which is a multi-system abnormality. It's an abnormality in the mTOR pathway, and you end up with abnormalities in the brain. So tubers, not tumors, tubers, abnormal cortical growth. You can have skin lesions, problems with the heart, the kidneys, and sometimes autism, sometimes a learning disability. There's another vast range of tuberous sclerosis, and they often start with infantile spasms, which are seizures that start, if I say nothing else today, important is spasms. So a head drop, arms up, look uncomfortable, starts in infancy, usually like 4 to 10 months. And these children, the seizures get worse. It's often mistaken for reflux. So if you see anybody that's having anything that sounds like that, we need to get them in as soon as possible to do an EEG. There's also CDKL5, which is an atypical Rett syndrome. So Rett's is in girls only, small head, their head stops growing and they start to have abnormal movements like wringing of their hands and developmental delay. So all of these have specialized medications that we can treat with. So recently approved newer medications, Diacomet or stiripentol was used in Europe, was just approved in the United States for people with Dravet syndrome. So children 2 years of age or older and already on clobazam. Epidiolex or cannabidiol is the pure CBD. It was approved starting back in 2018. It's approved for Lennox-Gastaut, Dravet, and also for tuberous sclerosis. Xcopri is cenobamate. It's indicated for the treatment of partial onset seizures in adult patients, and we're doing research now in kids. There's Ztalmy or ganalaxone. It's approved for treatments of seizures associated with CDKL5. So that's the atypical Rett's in patients 2 years of age and older. And then Fintempla, which is fenfluramine. That's the old fen-phen, but they've taken away one of the ingredients. And that's approved for Lennox-Gastaut and Dravet in patients 2 or older. So these are newer ones that you guys may not be aware of. There are also always new research studies going on. So some of the pharmaceutical companies that are recruiting now are Noema for people with tuberous sclerosis complex and seizures, Takeda for Lennox-Gastaut syndrome, Longboard for Lennox-Gastaut. Xenon is a potassium channel drug for focal seizures. And there's also a study of RNS responsive neurostimulation in children under 18. And these are all recruiting at the moment. Now let's talk also about rescue medications, because this is rather new. Everyone knows about Diastat rectal diazepam. I'm sure many of you have used it, but in the last few years, there's been FDA approval of newer medications in the form of nasal sprays. So approved for acute repetitive seizures or prolonged seizures for ages 12 or over is Nasalam, which is nasal midazolam. Ages 6 and over is Valtoco, which is nasal diazepam. But under 6, we're still having Diastat or the rectal diazepam, and you can see the pictures there. And your provider will be able to teach you how to use that. But it's important to ask for a seizure action plan and also to make sure that you have rescue medicine on hand and that everybody involved knows how to use it and where it is. Now, let's talk also about epilepsy centers. So this is a plug for having people evaluated at level 3 or 4 epilepsy centers. So there is something called the National Association of Epilepsy Centers. A level 3 epilepsy center does basic neurodiagnostic evaluations. They can offer evaluation for surgery, do straightforward resective surgery, and vagal nerve stimulators. A level 4 epilepsy center, on the other hand, has more extensive treatment and provides evaluation for epilepsy surgery and does epilepsy surgery, including intracranial electrodes that are placed right on the brain or in the brain, and a broad range of surgical procedures, which includes resections, corpus callosotomies, responsive neurostimulation, deep brain stimulation, laser ablation, et cetera. And I'm going to talk about those things. So of the epilepsy centers in New York State, we have 15 adult and pediatric level 3 and 4 epilepsy centers, 2 that are peds only and 2 that are adult only. Now, where I am at Westchester, we have peds is accredited, adult will be accredited this year. So what's striking about New York is that of the 15 epilepsy centers, 7 are in New York City, 2 are in Westchester, and 3 are in Long Island, which leaves Buffalo, Syracuse, Albany, and Rochester. So we have a big area between Albany, Syracuse, Buffalo, and Rochester and Westchester where we don't have great coverage. So this is a plug that if your child is having uncontrolled seizures, please get yourself to one of these epilepsy centers for a full evaluation. We evaluate and treat and make recommendations at these centers, but we send you back to your local neurology team, and we are more than happy to work with them so that you don't have to schlep down. We also all provide telemedicine at this point, so it's a little bit easier. There are some disparities. There are 8 states that have no level 4 epilepsy centers. The centers, as you see, are clustered and populated in metropolitan areas. The disadvantaged counties are less likely to have level 4 centers. And then I'm going to talk about epilepsy surgery and the disparities with epilepsy surgery and people not being referred. So oftentimes, people who have multifocal or generalized epilepsy have genetic epilepsy or normal MRIs, or if they have a concomitant either developmental delay or a mental illness, they're not referred for epilepsy surgery. Rates are also lower among Hispanic, African American, and certain Asian patients. And only the people that are really going to have a better outcome for resective surgery are more likely to be referred for surgical evaluations. And we want to change that. So what do? We do a surgical workup. So the other option is, so we've done medications. We've talked about medications. We've talked about rescue meds. We've talked about having a surgical workup, and we've talked about the risk, the workup in a epilepsy center and the risk of sudden unexplained death in epilepsy. So now the other option is there's an option of a ketogenic diet or a couple of other diet options, which I'm not going to talk about that much today. They're hard to be compliant with, and they require monitoring by a nutritionist, dietitian, and your epilepsy provider with regular blood work and changes of your meds for things that are ketogenic diet compatible. Then the third option is a surgical workup. So when we do a surgical workup, we bring you into the epilepsy monitoring unit. We do a full health assessment, medical history. We do a video EEG. We may do a stereo EEG, where we put the electrodes directly into your brain, and we do MRI and PET scans. And then we have a whole multidisciplinary conference to talk about what your options are. So surgical options are 3. There's a minimally invasive surgery, which is laser ablation. There's neuromodulation, which is RNS or responsive neurostimulation, deep brain stimulation, or vagal nerve stimulation, or an invasive surgery, which is an open resection or a corpus callosotomy or hemispherotomy. I'm going to talk about these a little bit. So laser ablation it's robot guided. A small incision is made in the skull, and the procedure is performed in an MRI machine. The laser goes in, and the surgeon precisely burns the affected tissue to eliminate the seizure focus. Hospital stays are usually a day or 2. Not all places have laser. There's a responsive neurostimulator, which is a device that's implanted in the skull, with electrodes that go into the brain. So it's almost like you have an EEG going on all the time. So it reads where the seizures are coming from, and then it stimulates to stop the seizures. The patient uploads the information on a laptop computer, and then that's uploaded to the cloud so that we can look at it remotely. There's deep brain stimulation. This is implantation in the chest, and the electrodes are channeled up to the brain. This just continuously gives off stimulation. It's not responsive. So it can't read where the seizures are coming from, but it does deliver stimulation. It's used more for Parkinson's and movement disorders at the moment, but we're also using it for seizures. Vagal nerve stimulation is the oldest of all the neurostimulations. All of these are palliative. So this is a device implanted in the chest, and it sends small pulses of electrical energy to the vagus nerve. So there's a little wrap around the vagus nerve in the neck, and we program it to send electrical stimulation, which then changes the neurotransmitters in the brain and stops seizures. All of these take some time to work. Then there's a resection. So if you have an area that's abnormal in the brain and that correlates with the EEG findings, then we may want to resect that. We do brain mapping to make sure that we're not removing anything that is eloquent. So not anywhere that speech is located or movement is located, and we're very careful about this. So that's a resection. Then there's a corpus callosotomy, which severs the connection between the two hemispheres of the brain. This is usually used for atonic or drop seizures, and this can be done also with laser, or it can be done with an open approach. Open resection I just talked about. The diet, so ketogenic, modified Atkins, or low glycemic. And again, what you're basically doing is cutting down on carbohydrates and eating proteins and fats. So again, you have to supplement. You're not getting all your vitamins and supplements, and you have to work with a dietitian. You can only be on it for a couple of years with frequent blood work. It can, in children, have some growth problems associated with it. So that's another reason for only doing it for a couple of years. All of the big epilepsy centers have the availability of the ketogenic diet. And now challenges. So these are some of our guys whose things have fallen off their faces. But the problems are that some of the patients may be nonverbal, they may have trouble communicating, they may be self-injurious, and they may have injuries that occurred from the seizures that make it hard to get them in for testing. All right, now I'm going to talk a little bit about the reasons for getting in quickly to treatment by an epilepsy specialist. So sometimes what happens is the person who's seeing you is not able to identify that the patient has a typical syndrome. They may not have been seen by a pediatric provider. They may not have been seen by someone who specializes in epilepsy. And then back to the infantile spasms. Remember, I told you about head drops and arms up and being mistaken for reflux. So that's really important. Sometimes you get a kid that years later, they'll have really intractable epilepsy, and you'll say, I bet this child had infantile spasms. So infantile spasms needs to be aggressively treated at the time of onset as quickly as possible. They also can miss things like Lennox-Gastaut, not identifying that, Dravet syndromes, not having noticed that they are a candidate for a surgical option. They may be on polypharmacy. So that's what we call it when you're on 3 or 4 different medications for seizures and still having seizures. So this happens when you add on medication after medication without taking one of the others away or referring for diet or surgery or specialty meds. And people may have difficulty getting in. So if they're in an outlying or a rural area, you may have difficulty with transportation. In urban areas, you can still have difficulties with access because sometimes there's a call center and you can't get through to make an appointment. You may not be able to get transportation. You may not be able to get in because you have childcare issues or you can't lose a day of work. I have lots of patients who've lost their jobs because they were called so many times to pick up their child. Now let's talk about seizure detection devices. We talked about rescue meds and we talked about seizure action plans. The other part of keeping people safe is having a seizure detection device. So there's something called a SAMI camera, which is a camera in the ceiling that picks up any of the movements and records them and alerts the caregiver's phone. There's also an Empatica watch and an Embrace watch. And they look kind of like Apple watches, and they are rooted to the caregiver's phone and they alarm if there's some unusual movement going on. All right, again, there is a need for further research on wearable devices so that we can clinically validate them. We want to make sure that the seizure detection is working carefully and that patient preferences and costs are taken into consideration. So this is a guideline for the International League Against Epilepsy, stating that we really need to do more research on seizure devices and wearable devices. All right, and this, we're going to skip this part. So things to remember are to identify genetic abnormalities early, identify drug-resistant epilepsy early. So this is 2 failed meds, 2 of the correct meds for the type of epilepsy. Once you fail 2 meds, you're drug-resistant and you need to go on and look at different medications, more of the newer medications, things that work well together, and also to see if you're a candidate for surgery or for diet. Early referral to an epilepsy center, early referral to support groups and foundations. There's the LGS Foundation, the CDKL5, there's the Dravet Syndrome Foundation. The next slide has pictures of all of them. It's also important to address the comorbidities. Oftentimes the comorbidities are more of a problem. So it's the stuff that goes on at school, the behavioral stuff that are harder for parents and caregivers to deal with than are the seizures themselves. You know, the seizure, you're kind of in the heat of the moment, it's an emergency, you give the rescue meds, but it's the day-to-day behavior and not sleeping and learning support that's needed that can wear parents out even more than the seizures. And then also to address the long-term needs. So these are things like guardianship, OPWDD, Access VR, the things that can help your child live a full and happy life. All right, and here we have a bunch of the different groups. So the National Association of Epilepsy Centers, these are great places to get support and to get information. So the National Association of Epilepsy Centers, I talked to you about, they have lots of things on the website. The acute syndrome is SNA8, so that's another sodium channelopathy. They have a great foundation and support group. The Dravet Syndrome Foundation, the TSC, Tuberous Sclerosis Complex Alliance, the International Foundation for CDKL5 Research, and the Lennox-Gastaut Foundation are really great organizations led by parents and families, do amazing research, amazing support. And then we also ask people, if they're looking for information on epilepsy, not to Google it, but to look for these websites. So the Child Neurology Foundation, Association of Child Neurology Nurses, which is associated with the Child Neurology Society, the American Epilepsy Society, the Epilepsy Foundation and Epilepsy Alliance, and then to look for the seizure detector devices. Everyone should have a seizure action plan and everyone should wear a medical alert bracelet. And so that is it. Do we have any questions? No, I've stunned you all into silence. Questions at all? No? All right, so Rachel, thank you so much. I am so sorry, everyone, that I was late. Completely unavoidable. I tried, but I appreciate you all sticking with me to the bitter end. If you need any information, please feel free to contact Rachel and the Epilepsy Foundation of Northeastern New York. There's a whole consolidation of all the epilepsy foundations and epilepsy alliances, which I think is fabulous, and we're really looking forward to working with everyone together. I cannot thank you enough for inviting me today, Rachel, and I'm so apologetic.
No worries at all. We completely understand. Patients come first. So we appreciate you having your time, giving us a little bit of your very, very, very busy schedule. So thank you
We'll
so
do
much
it
for
again,
this
right?
great
I'd love to do
information.
this for those guys.
Absolutely. Thank you for this great information. If anybody has any questions, feel free to reach out to me. And if we cannot answer them for you, we will definitely connect you with Ms. Patty.
Hi, I do have a question.
Yeah.
I do have a question. Hi. Yeah. So I did get the brochure and I see that there are educational programs being offered. So as a nurse educator, I wanted to know, how do I connect to get an educational program for my students?
Sure, absolutely. What county are you located in?
I'm in Orange County.
Orange County? Okay, so we actually only go down to Sullivan County, but I can connect you with the director of the affiliate that is in your territory.
Okay.
So did you email me this morning or yesterday?
Yes, I did. So you got my
Okay.
email.
I got your
Yeah.
email. I will connect you with the executive director or the educator down there with you.
Okay, that
what
sounds
school-
good.
What school district are you in?
So no, I'm actually in the nursing program at SUNY Orange.
I know
Yeah,
one of
so
your preceptors.
I'm sorry.
I know somebody who works with you, which of course divulge.
Of course, it's just a lot. I'm sure there are plenty. Yes, and I'm familiar with Westchester Medical as well. So yeah, so that was the reason why. Thank you, Rachel, because you did see my email. How ironic! We were teaching about epilepsy and seizures last week on campus, so I thought this would be a great tie-in. Of course, for next semester because not now, but however you can help us, that would be great.
Absolutely. I will definitely get you that connection.
Rachel,
Okay.
that's a
you.
good point. Somebody had a seizure in my office yesterday, a big guy, and all my office staff were like, "Oh my God, he's having a seizure." So really, it's important that everybody knows basic seizure first aid, and I'm going to go back and have an updated educational seminar with them. I think everybody just sort of panicked. But I think even for kids, the school kids, you guys do this all the time, but it really brought it home yesterday.
Absolutely. Well, I hope that they had the right reaction there, but
Yeah, well, I was there, so
yeah, fair.
thank God.
Awesome. Great. Well,
Right. Thank you again, everyone, for coming. Rachel and
Thank you,
Janine,
Patty.
much. All right, bye-bye.